Out the poster presentations. We're pleased to have you join us for our first patient-focused concurrent session of the afternoon. So hopefully, if you need to get your coffee, your water, whatever it's going to take, we want to make sure we give our speakers their full attention because I think it's going to be a fantastic, phenomenal session. We can see from our speakers here. My name is Dr. Dana Powell, and I'll be moderating this session, Renal and Pulmonary Hypertension Complications in Sickle Cell Disease. So before we begin, I would like to share a few brief housekeeping reminders. Please ensure that your phones are muted. Kindly refrain from side conversations during the presentations as we want to give our speakers our full attention. The washrooms are located outside the hall on the right side. We're going to close that door in a bit so there's no distractions, but of course you have access to get in and out. Wi-Fi access information is available on the screen. We also encourage you to complete the session survey at the end of each presentation because without your feedback, we cannot make improvements and make you happy next year and every year to come. So that's our aim, to just continue to move things upwards and forward. And we need you for that. Awesome. So without further ado, are you as excited as I am for this phenomenal panel? Let me introduce them. Many of you probably recognize them, know them, but I'd like to introduce you first to Dr. Andrea Cervi. Excuse me. She's an adult hematologist and physician lead of the Adult Sickle Cell Disease Program at Windsor Regional Hospital, where she has developed and advanced a comprehensive person-centered model of care for individuals living with sickle cell disease. She also serves on the Ontario Health Sickle Cell Disease Advisory Committee as a clinical representative for Southwestern Ontario and is committed to advancing sickle cell disease education and quality of care. Next, I'd like to introduce you to Dr. Melanie Kirby-Allen, sorry, I just call her Dr. Melanie Kirby, so I did that. Dr. Melanie Kirby-Allen. She is also close to my heart. That wasn't in the script, but I'm going to say that. Phenomenal leader and mentor in the community. But she's a full professor in the Department of Pediatrics at the University of Toronto and co-director of the hemoglobinopathy program. That is meant to be a tongue twister, isn't it? She completed her medical training at the University of the West Indies, followed by pediatric residency and subspecialty training in pediatric hematology oncology at Queen's University, SickKids, and the University of Ottawa. Dr. Kirby-Allen has been recognized for her excellence in teaching, mentorship, and service to children and families living with sickle cell disease. Next, I'd like to introduce you to Dr. Donnell. He uses his personal and professional experiences to improve care for individuals with health conditions, including sickle cell disease, and currently serves as the Chief Medical Officer for the Sickle Cell Disease Association of America, SCDAA. He previously served as Program Director of the Hemoglobinopathies Program with the Maternal and Child Health Bureau and was part of the National Heart, Lung and Blood Institute team that developed the 2014 NHLBI sickle cell disease treatment recommendations. So without further ado, I'd like to invite our first speaker to the platform, and please help me to welcome Dr. Andrea Cervi.
Thank you very much, Dr. Powell, and I'd like to thank the summit organizers for the opportunity to speak to you today. I'm going to be talking to you beyond the red cell, really focusing on renal complications in sickle cell disease with a very, very brief mention of some pulmonary vascular diseases as well. So in terms of our learning objectives, I'll sort of be setting the groundwork for sickle cell disease as a complex, multi-system, multi-organ disease, really evolving into the pathophysiology and some other characteristics about kidney disease and sickle cell disease, and again, ending very, very briefly with pulmonary hypertension because Dr. Kirby-Allen will be going through this in her session. In terms of my disclosures, I have received honoraria from Novo Nordisk and Leo Pharmaceuticals. My other disclosure being that I have a sick toddler, so I apologize if I break out into song midway through. I don't think I need to speak too much to this room about the fact that sickle cell disease is an inherited disorder of the red blood cell, and it quite literally can impact every organ system in the body from head to toe. Okay, it can do so in acute or episodic manifestations, and how we recognize that mainly is through acute vaso-occlusive pain episodes or pain crises, but it can also have acute presentations such as acute chest syndrome or stroke or hepatobiliary, so liver or abdominal manifestations. It's important to recognize that there's a cumulative impact of repeated organ injury, and so we can see many individuals impacted by pain on a daily, long-term, chronic basis. Beyond this, we can see that sickle cell disease can result in heart disease and heart dysfunction over time, specific lung disease, eye disease, alongside bone and eye complications. And so recognizing this, one of the key components of our outpatient comprehensive care clinics is in the chronic health maintenance of individuals. And I'm a fairly simple person, so I really do try to just take a head-to-toe approach. So starting in the head, we emphasize and we focus on the impact of sickle cell disease on neurologic function. I'm an adult physician, so I do reference a lot of adult guidelines. And so for adults, there's a recommendation for all individuals to have at least one baseline MRI throughout the course of their lifetime, with subsequent follow-up dictated by the results of that imaging. And what we're looking for is impacts of the disease on blood vessel abnormalities, particularly in the brain, or potentially evidence of silent injury to some of the brain tissue. We're screening this with our patients by asking things such as memory loss or memory deficits or difficulty concentrating, maybe in school or outside of school in the workforce. We're also asking about sleep-disordered breathing, recognizing that this can differentially impact people with sickle cell disease as well. Moving down to the eyes, sickle cell disease can impact on eye health in a number of ways, but one of the more obvious ways that are screened for on a very regular basis is by looking at the impact of the disease on the small blood vessels at the back of the eye. And so we are recommending that individuals go at least once a year, a very specialized eye exam, so that those small blood vessels can be seen, because if there is early disease there, then there are treatments that can prevent progression that can lead to blindness. Sickle cell disease can impact on the heart and the lungs in a variety of ways, and there sometimes is a little bit of debate as to how we screen for that, whether it's just through clinical assessments or it's tied to routine imaging. But regardless, we are ensuring that this aspect of chronic health maintenance is taking place as well. Next, we move on out of the chest into the abdomen, and that's where we know that we can see impacts of sickle cell disease on kidney health, and usually we're screening through that through questioning such as inappropriate bubbles or foam in the urine, or maybe blood that people are occasionally seeing in their urine. Can impact on the liver and the biliary tree. That's the complex system that links the liver to the intestines, and so we're asking about things like pain after eating, or maybe some impacts of medications such as opioids on bowel health in general. Beyond that, reproductive health is really key, and so one of the ways that sickle cell disease can present in males is it can cause an entity called priapism, which is very painful, prolonged erections, and sometimes patients are not necessarily very willing to talk to healthcare providers, but it's an important symptom to ask about in the clinic. It's also important to address safe contraception options for those who are interested, and to make sure that we're promoting and laying a groundwork for familial planning for people who are interested in later having children. Bone health is also key, so over time sickle cell disease can weaken the bones, and so we are screening for that through entities in the blood along with imaging. And then, looking at all of these boxes and recognizing that this is an inherited lifelong disease that impacts on all of these systems, we recognize the impact of this on mental health, and so screening and discussing things such as anxiety and depression is really key, ensuring that our patients have an outlet and an entity to talk to about these things. One of the wonderful things that was spoken to by Dr. Newton earlier, linking with SCAGO and different peer support groups is also really, really fundamental here. And then one of the things that we do emphasize a lot in the clinic is preventative care. And in sickle cell disease, a lot of that revolves around vaccinations and immunizations, recognizing increased susceptibility to certain infections. But it's also important to ensure that people are getting routine preventative care outside sickle cell disease. So are people also getting age-appropriate cancer screening? And then it's also an opportunity to talk about disease-modifying therapies. And so there's a lot of discussion about hydroxyurea. Is there an opportunity to augment or optimize the dose? And is there the potential for referral for other more specialized cellular therapies like stem cell transplantation, which we heard about this morning too? So for the next few slides, we'll be really focusing on the impact of sickle cell disease on kidney health and kidney function. So using an illustrative case, Mr. AM, he's a 22-year-old gentleman with hemoglobin SS disease, and he's originally from Nigeria but moved to our area a few years ago to pursue schooling through our local university in political sciences. And so fortunately, shortly after moving, he was linked in with our comprehensive care clinic. And at one of his visits, he says, you know, doctor, last time I saw you, you sent me to the lab and I had blood work done, and then they asked for a urine sample. So I'm wondering why it is you want to look at my urine when I have a blood condition. And we said, well, that's actually a really good question. So why do we want to look at your urine when we're monitoring for a blood condition? I think before we can understand how sickle cell disease impacts the kidney, we do have to go back a little bit, and this was a little bit painful for me, but I thank SCAGO for the opportunity to do this. We have to go back and understand normal kidney anatomy. So the kidneys are these bean-shaped structures. They sit sort of in the mid to low back on either side of the spine, and they're quite demanding organs. They receive about 20% of our cardiac input every day. When we think about the kidney, we can kind of do this in 3 different architectural designations. So firstly, thinking about gross anatomy. So the outer portion of the kidney is the cortex. That inner portion, that inner portion in there is the medulla. That's a very high oxygen consumption environment. We can also think about the kidney in terms of its kind of collecting and drainage system. So blood enters the kidney through that renal artery there, exits through the vein, and then basically through a series of these tubes, the waste is excreted through urine, and that sort of links up into that larger tube there, the ureter, which ultimately leads to the bladder. And then we can think about the kidney from a microscopic perspective. And so that is that single functional unit, which is called the nephron, and that's really where a lot of the magic of the kidney happens. The kidney is really important in terms of modulating water regulation, fluid balance, acid-base control, electrolyte balance. It's very key in our blood pressure regulation, and it also has an important role in red blood cell production because one of the main synthesizers of a hormone called erythropoietin is actually the kidney, and that's very important in terms of signaling to the bone marrow to make new red blood cells. Okay, so blood is entering through that renal artery there, that red, oh my goodness, eventually I'll get this, that larger red artery there, and that artery is then dividing into a series of smaller, finer little arteries and capillaries, and it's ultimately culminating in this kind of worm-like structure here of blood vessels called the glomerulus. And that's really sort of the fine point of the kidney where essentially waste is sort of being created there because that glomerulus is lined by this complex tubule network here, and the good stuff is staying in the bloodstream, but the bad stuff eventually is making its way into those tubes and it's exiting the kidney through the ureter. In sickle cell disease, the kidney is particularly susceptible to injury, and one of the big reasons for that is that medulla, the inner portion there, is a relatively oxygen-poor environment, and it's also quite acidic, and it has to be to do its job. But we can imagine that blood entering in through that renal artery when it's meeting this low oxygen acidic environment, it's having a tendency towards sickling. And so we do see that there's increased prevalence of sickling, particularly in that area of the kidney, and over time that's leading to occlusion, impaired blood flow delivery, and it's setting up an inflammatory cascade. And so early on when this process is happening, The kidney has a number of very intricate autoregulatory pathways, so it will sense that it's not doing the right job, and it will try to compensate by overfiltration. And over time, what we see is that there is damage to those little blood vessels that happen there. They become larger, they become thicker, and they aren't functioning as well. And so they start to spill normal protein into the urine. And the protein that we can detect in the urine is albumin. And so increased albumin in the urine is one of the earliest markers of kidney disease in people with sickle cell disease. And with time, what we see is that as this process continues, there becomes more inflammation, more death of those tubules, those structures. We see more fiber deposition, and that's how we're detecting poor kidney function in the blood. And if left untreated, that can progress into overt kidney failure. Okay. So kidney disease significantly impacts on life expectancy in people with sickle cell disease, and we know that people with kidney disease, with sickle cell disease, have worse outcomes relative to people with kidney disease from other causes. So there's increased incidence of death and increased incidence of hospitalization. Beyond that, I think we recognize that no organ functions in isolation, and this is a disease that really impacts all organ function, and so kidney disease really amplifies other morbidity. So it is associated with increased risk of developing other complications like pulmonary hypertension, like heart disease, like worsening anemia and need for blood transfusion and dehydration. So how do we start to screen for this so that we can detect this condition and start to implement management strategies before it has a chance to progress and become basically kidney failure? So most guidelines would say that starting at the age of 10, at least once a year, individuals provide that urine sample to look for evidence of that albumin or that protein spillage into the urine. And that's usually done in conjunction with a blood test called creatinine, which is not the best indicator, but it's an indirect indicator of kidney function. Okay, so these are Canadian units for you here. So essentially, a urine albumin to creatinine ratio of less than 3 is considered normal. We can go back to business as usual and continue to screen once a year. But if we're at 3 or higher, we need to repeat it, mainly because there can be some transient situations that lead to an elevation in that value. So it may not necessarily be in the setting of sickle cell renal disease. But if it's present on repeat, then we know that we are dealing with early indicators of kidney disease. And in those instances, depending on how things are progressing and how bad it is, we might be making a referral to our friendly neighborhood nephrologist for some of their input. Okay, the treatment of kidney disease in people with sickle cell disease is multi-pronged, as is many entities in sickle cell disease. So we can think about how we optimize sickle cell disease therapies, and by and large, we do revert back to hydroxyurea. There have been studies demonstrating that hydroxyurea can serve to halt some of that protein spillage in the urine. There's a little bit of a lens on the fact that hydroxyurea to some extent is filtered by the kidney, so we do want to be careful there. There may be a role for blood transfusion. This has not been as well borne out in adults with kidney disease, but there is some data supporting this in the pediatric population. But I'm not a pediatrician, so I don't want to anger my pediatric colleagues here. And then potentially cellular therapy, but really the long-term impact of cellular therapies like stem cell transplant on established sickle cell kidney disease are not well known. And then there are kidney protective therapies, so classes of medications like ACE inhibitors or ARBs, which traditionally are used to lower blood pressure, but those medications can help to reduce that protein spillage. And then I think in tomorrow's session, we'll learn about some emerging therapies that help to augment oxygen delivery, blood deformability, and other elements of sickle cell disease care that may have benefits in the long term for kidney disease as well. Looking at complications of kidney disease, we also need to monitor there, so ensuring against dehydration. Oftentimes, I shouldn't say oftentimes, but sometimes people can see blood in the urine. That's typically managed supportively, and it does resolve on its own, but obviously something that we want to know about in the clinic. The kidneys are important for blood pressure regulation, blood pressure can elevate in kidney disease, and that can actually worsen the kidney disease with time. So we're making sure that we're monitoring for that and treating it appropriately, measuring for any issues with electrolytes like high potassium or high acid levels in the blood. Again, we can see worsening anemia with time, and in people who are progressing again to overt kidney failure, then we're looking at other kidney replacement strategies like dialysis or sometimes kidney transplantation. So going back to our gentleman, about 9 months later on, he comes to the clinic. This time there's a bit of a different issue, though. He's not really coming for just kind of a chat and a check-in. He's worried. He's noticing that he's more short of breath and he's got some swelling in his legs. And so I won't go through this in detail because it'll be covered in our next session. But he has a new diagnosis of pulmonary hypertension now. And very broadly speaking, that's an increase in the blood pressure in the vessels in the lungs. And we know that there is a link between individuals with kidney disease and pulmonary hypertension. So again, this will be covered more so by my colleague here, but just like kidney disease, this does need a multi-pronged approach to management, usually with a pulmonary hypertension center of expertise at its core there. And so just to end off, really, I hope what I got across is that while this is a disorder that impacts on the red blood cell, it has system effects that span the body, and we really do need to be mindful of how we appropriately screen for that diagnosis, and really early detection is key so that we can prevent things from getting worse. I thank you so much for your time, and I'm happy to take any questions when we're allowed to.
Awesome. We're going to welcome Dr. Melanie Kirby-Allen to the podium.
Do you hear it forward and backwards? Do you have a light?
Yes, this one right here.
Okay.
Yeah.
All right. Good afternoon, everyone. Thank you for having me. I'm going to talk about pulmonary hypertension. Nothing to disclose affecting this talk. I do have studies that we're running with Novo Nordisk and Pfizer. So the objectives of this presentation would be to discuss prevalence of pulmonary hypertension in people affected by sickle cell disease, to review the pathophysiology, understand diagnosis from the patient's point of view and the physician investigations, current screening recommendations, and a brief word on prevention and treatment. So pulmonary hypertension, we just heard, has been reported to affect about 10% of patients, adults with sickle cell disease. It's more an adult disorder. We do screen periodically in pediatrics based on the history, but currently we have no one that we're treating for pulmonary hypertension, just to give an idea of the prevalence. Individuals affected by sickle cell disease face the most significant risk due to lifetime of ongoing severe hemolysis, anemia, chronic inflammation, and vascular injury. The pulmonary complications are of particular importance. Acute chest, which many of you are familiar with, and pulmonary hypertension have the highest associated mortality rates. So I'm going to, oh, this doesn't show up very well. Okay, it doesn't show up very well, but don't be intimidated by the complexity. I will make it a review. So pulmonary hypertension, we saw briefly on the last presentation, can be their precapillary, which is usually lung vessel issues leading to pulmonary hypertension, and postcapillary, which would be related more to heart, and a secondary backup of flow into the lungs. So with sickle cell disease, we break down red cells, and that results in a significant anemia. Patients are chronically anemic, so your heart is pumping more, a stronger pump because there's less volume to pump out, and that results, that results in, it doesn't show here very well. Is there a chance of just decreasing the lights at the front? Just over here, maybe that would show it better. So the chronic anemia results in the heart pumping more strongly. The left side of the heart gets, if you look at chest x-rays of patients with sickle cell disease, the left side of the heart is a much thicker muscle, generally. And the left side of the heart being in the muscle mass increases, that results in increased pressure from the right side, from the left atrium into the ventricle, and that results in a backup of flow into the pulmonary vessels. On the other side, breakdown of red cells, there's release of heme, free heme. Free heme results in nitric oxide depletion. Nitric oxide helps us to vasodilate, increase the diameter of blood vessels to allow good flow. So when nitric oxide is reduced, we get vasoconstriction or narrowed vessels. So that's decreasing the size of the diameter of the vessels, so putting backflow onto the lungs. We also have, with red cell breakdown, free heme is also associated with inflammation, and that results in endothelial injury. So the lining of the pulmonary vessels gets injured, and there's inflammation. Our body heals with an inflammatory response and scarring, and that increases the thickness of the vessels, so increasing the pressure within the vessels. And then we also have small thrombi or clots being formed within the blood vessels, which further increases the thickness of the wall of the blood vessels and also decreases the diameter of the blood vessels. So overall, the pressure within the lungs increases, both from the effect of the free heme and endothelial damage and clots forming, and also from increased cardiac output and backflow into the lungs. This is just a picture to show you a cross-section of some of these blood vessels, what happens. So just take this one, for example. If you cut across a blood vessel, that's what you're seeing here. There's increased musculature within the wall and clots within the wall, and so in this vessel there would be very little flow, and then they get some opening up at times of the clots within the wall, and you get channels which blood continues to flow through, but obviously it's not flowing freely. So what do the patients experience? Oops, what happened there? Oh, okay, go backwards. What do patients experience? So many of our patients have different levels of hemoglobin, low of anemia, and with anemia, your exercise tolerance would be less than a pair of the same age and doing similar activity. But what you would notice is progressive shortness of breath with exertion. So if over time there's climbing stairs, for example, it has becoming more and more difficult, that's a red flag to get investigated. If you're having chest pain with exertion, that's another one. Lightheadedness, and if you're actually fainting, that's significant, a significant poor prognostic factor. So overall, a history of progressive dyspnea, or shortness of breath, exertional chest pain, lightheadedness, syncope is what you would recognize, and you should bring that to your physician's attention. What the physician would be looking for with that history would be exercising you and doing an oxygen saturation and noticing that your oxygen saturation is lower, an examination of the neck where there's an increased jugular venous pressure, and you might see that pulsating in the neck. Different heart sounds which shouldn't be there. So an increase, normally you hear boop, 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 first and second heart sound. Hearing a third or fourth heart sound is significant. Hearing murmurs that weren't there before is significant. And hearing a fixed second sound, where instead of boop, 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 when you inspire, you go boop, 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 but if that's, and that varies. If you take an expiration, it goes down. If you inspire, it increases. But if it's fixed, that. If you examine the patient and the left side of the beside the sternum, there's a lift. If the liver is getting enlarged and pulsating, or if the legs are getting swollen, that's all things that we should be looking for. So the first test to evaluate based on the patient's history is an echocardiogram. And there's a measurement called a TR jet of 2.5 meters per second is predictive of pulmonary hypertension. But not only that, what we would want to have done is a pro-BNP levels, which is a blood test, and a 6-minute walk test. And these three things together should indicate that if they're abnormal, a walk test, which is not being able to walk as much as suggested for 6 minutes, shortness of breath on exertion, TR jet that's abnormal, and the blood test that supports that, then you should be getting a right heart catheterization. Other tests that can compound, other factors that can compound pulmonary hypertension is asthma. If your asthma should be under control, because that just makes things worse. Looking for clots, if you have pulmonary emboli, clots in the lungs, that gross clots in the lungs that should be taken care of. And we mentioned sleep disordered breathing, so hypoxemia at night from sleep apnea. In children, we have lots of large tonsils and adenoids. We take them out and the hypoxemia gets better, or in adults without tonsils and adenoids being enlarged, CPAP might be one way to help with decrease. And then we heard a little bit about iron overload assessments if there's a history of significant transfusions, because that just makes things worse also. Screening recommendations. All adult patients should undergo screening on an annual basis. If the TR jet is normal, less than 2.5 meters per second, then you just do it the next year or 1 to 2 years. If it's elevated, then you get screened with the blood test, the 6-minute walk test, as we mentioned before. In pediatric patients, we tend not to see pulmonary hypertension very much, but if we had a history, then we would do all of the above also. What can we do to prevent? We recommend strongly hydroxyurea for everybody with sickle cell disease, and that is one of our preventive ways. Chronic transfusions have a role to play on an individual basis. A referral should be made to a cardiologist or a pulmonologist who's familiar with pulmonary hypertension in sickle cell disease, and then individual decisions made regarding treatment based on the individual patient in association with the sickle cell your sickle cell team and cardiologists. So in summary, pulmonary hypertension is not a single disease, but a spectrum of hemodynamic phenotypes. This is all driven by anemia, hemolysis, inflammation, hypoxemia, and clots. Clinical history is crucial for pickup and for patients to be aware to bring this to the attention of their physicians. Periodic screening is recommended, and treating physicians within the sickle cell clinic should be aware of this. Hydroxyurea, therapeutic and possibly preventative, and red cell transfusions have a role, but it's a combined decision regarding management with your sickle cell team, a cardiologist, or someone familiar with managing pulmonary hypertension. Thank you.
Help me welcome Dr. Donnell Ivy to the stage.
Great. Thank you so much for being here and allowing me this opportunity to talk to you. I kind of debated how I should go with my presentation. Should it be more on the scientific side or personal side? I kind of tried to go in the betweens, but I'm going to actually present it more from the personal perspective. So you already heard from Dr. Cervi about kidneys and what they do and how they work. And you have to realize that kidneys, they do a lot of work. So they filter about 200 quarts of fluid every day. That's enough to fill a large bathtub. So they're active, they're really active in trying to remove waste, including nitrogen waste, muscular waste, and acids from the body. And so this is a very tough environment for red blood cells. As it was mentioned by Dr. Cervi, this is an area that's very acidic. It's what's called hyperosmolality, which means that it's very kind of like dense in terms of ions that's moving back and forth. And then it's also an area where the red blood cells can lose their oxygen and become sickle. So in the part of the kidney called the vasa recta, you can actually get a lot of damage occurring. And this can actually happen at very young ages. So you can start seeing changes in the kidney cells from 1 to 3 years of age. And personally, if I use myself as an example, I just known all my life that I had to use the bathroom frequently and I needed to drink a lot of water. Then I talked to doctors and it's like, yes, so because of kidney changes that you see, individuals with sickle cell disease, they have to use the bathroom a lot and they have to also kind of stay hydrated. So that was one of the key messages for me as a kid, is making sure you stay hydrated. And that happens because the kidneys lose that ability to really concentrate the urine. I'm not going to go into what that means, concentrate the urine, but you run into a situation where then you're losing a lot of fluids, and that can become something that is very damaging, because that can then lead to dehydration, which with sickle cell disease can lead to additional problems. There's also, as Dr. Cervi mentioned, impaired potassium excretion, and that can lead to certain issues that an individual can have. You can get hyperuricemia from proximal tubular function, and then there's the glomerular disease. So what you see first is that there's that hyperglomerular filtration, where you get increase in what's called the GFR. But then over time, as kidney damage progresses, then you will see a drop in that GFR. And I would say that, I'm glad that I have a chance, since Dr. Cervi covered most of it, to talk to you personally, because I, experienced a lot of this as a child, the dehydration, but it wasn't until I was in my 20s that hydroxyurea came about. Hydroxyurea is changing some of this, so we're not seeing in kids. In some cases, we're not seeing it. And so in the United States, as an example, they try to start individuals on hydroxyurea very early in life, 9 months of age. I think they're starting to try to push it down. So hopefully we'll start seeing where we have children that are able to avoid some of these complications as hydroxyurea utilization or as better management of their disease is taking hold. One of the things, so now I'm going to talk to you as a patient, is that we really have to figure out how we get that message to patients and families, that you need to have some type of sickle cell disease coverage. I started taking hydroxyurea because I had an episode of acute chest syndrome when I was in my undergrad. And I was talking to the doctor, and I had the same questions that many of the other sickle cell patients had in terms of, well, should I start taking this as a chemotherapy drug? Is this, that? He said to me, well, look, you just had an episode of acute chest syndrome. And at the time, acute chest syndrome was one of the leading causes of death in individuals with sickle cell disease. He said, you cannot take hydroxyurea, have another episode of acute chest syndrome in 6 months, and then die from the acute chest syndrome, right? Or you can take the hydroxyurea, and could it cause cancer? Yeah, there's, the science wasn't firm on it, but, they didn't think it would. I've been taking hydroxyurea now for over 30 years. I started in 1995. And I've been very fortunate in that as I started taking hydroxyurea, it improved my sickle cell disease. I haven't had a pain crisis in well over 20 years. But what I have to realize, though, is that there's other things that sickle cell can do to you beyond pain crises that can really lead to, devastating results. And kidney disease is one of those. And I have to be honest with the group, is that this is what scares me the most, is sickle cell nephropathy, because it can be a very serious situation that can lead to death very early. So once you get end-stage renal disease, so when you saw on Dr. Cervi's slides, end-stage ESRD, end-stage renal disease, that's kidney failure. Then you have very limited options after that. There's dialysis, and then there's kidney transplant. And unfortunately, there's, individuals with sickle cell disease, they hadn't been looked at favorably for kidney transplant. We know from some of the scientific data that that's the best way to go, to have a kidney transplant over hemodialysis if you have sickle cell disease. But there's still issues with getting individuals with sickle cell disease on the transplant list. So that's another area that we have to work on, is making sure that we're educating doctors about, hey, if an individual has end-stage renal disease, then the best thing you can do for them is get them on transplant as opposed to hemodialysis. One of the ways we can do that, though, is that individuals with sickle cell disease should have a relationship with a nephrologist if they have complications. If they're showing signs of early renal disease, then they should have an interaction with a nephrologist. Now, I have stage 3 renal disease, and that usually sounds worse than it is. I say, "Ooh, I have stage 3 kidney disease," and everybody says, "Oh, I'm so sorry to hear that." It is bad, but it hasn't progressed, and I've been fortunate since about 15 years. I've had a relationship with nephrologists. I make sure I talk to nephrologists. I have biannual visits now with the nephrologist to discuss my maintenance, and I've been taking a medication called losartan, which is a angiotensin receptor binder inhibitor. That's a long word to say that it acts on the kidneys to improve blood flow through the kidneys. And in some cases, you may want to consider, is starting ACE inhibitor, they'll start you on that first. I started that and I had a cough, so I transferred over to the ARB. But the important part I'm trying to get down to you is that I love my hematologist, but I don't want them managing my kidney disease. I want to go to an expert that knows how to do it. And having that relationship can also help you if it comes time to be considered for transplant. They can then push the ball a little more than probably the hematologist can. So it's very important to make sure that as you're seeking care, you're asking those questions, you're getting these tests done so that you can be informed. Kidney disease is among the leading causes of sickle cell disease mortality in the modern age. So right now, after hydroxy or after this, we have to look at, now individuals are living longer. I went to a conference just not too long ago, and the theme of the conference is 50 the new 20. And it took me a minute to think about that. And so when I was growing up, I was told by doctors, my friends were told by doctors that, well, you probably won't live to be 20, right? Well, now individuals with sickle cell disease are living much longer. We're living into our 50s. But we have to look at then that now we are exposing ourselves to other complications that we need to treat ahead of time. We want to make sure that we're looking at kidney disease, we're looking at pulmonary hypertension, we're looking at some of these diseases ahead of time. I'm going to go ahead and just finish up. So things to think about, though. So my experience in childhood, the dehydration issue, the increased thirst, the frequent bathroom use, and the bedwetting can happen in individuals with sickle cell disease. But we also have to think of this in the context of students. An individual in school, with sickle cell disease, they may need more frequent breaks, water breaks. They may need more frequent bathroom breaks. And so it's not enough to just work with our hematologists, with our health system. We also have to work with our educational institutions, making sure that teachers are aware of this. We need to work with camp counselors, so if we have students that go away to camp, that they understand these requirements, that they understand that the individuals need to have increased breaks. So if we look at the pathophysiology real quick, we can see that there's repeated sickling that can happen, and this can lead to, of course, vaso-occlusive episodes. We know that there's the glomerular hyperfiltration that happens, tubular hyperfunction that can happen, and you get the endothelial damages. That leads to that inability to concentrate urine. That leads to the albuminuria, which is that protein that you're starting to see in your urine. It can lead to acute kidney injury. And then eventually that can lead to the chronic kidney injury, which can lead to kidney failure. So how do we try to manage this? We try to manage with annual screening, and this starts very early. We want to start at around age 10, looking at individuals. We want to make sure that individuals stay hydrated, and then as I mentioned, you may want to consider starting ACE inhibitors. As I mentioned, ACE inhibitors didn't work for me, so I had to switch over to ARBs, and then making sure you have adequate control of your sickle cell disease. As I had mentioned earlier, this is one of the things that scares me a lot. I have to admit I'm afraid of kidney failure. You can see from this curve that individuals that get kidney failure are more likely to die. So the mortality risk is about 2.8 times higher than those with individuals that are on dialysis whose kidney failure was due to other causes. So kidney failure due to sickle cell disease can be particularly dangerous for our population. So we want to make sure we're starting very early in educating individuals. And 26.3% of those individuals that died, they died within 1 year of starting dialysis. And not to sound morbid there. So what are steps we can take? As it was mentioned earlier, annual screening for proteinuria starting at age 10. We wanted to limit to use of non-steroidal anti-inflammatory agents. So this is another area to talk to your doctor. I have to admit that sometimes I still do take aspirin, but very, 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 very infrequently. You want to look at, hey, I'm going to use something else for my pain like Tylenol. I'm going to avoid those NSAIDs, those non-steroidal anti-inflammatory agents. And you want to also potentially look at the use of ACE inhibitors. So this is a schematic I got from one of the articles. And so in monitoring individuals with the disease, you want to first monitor for the proteinuria. If the screening comes up positive, you then want to screen for other possible causes of kidney disease. So it's very important to understand that there can be other causes of kidney disease, even in individuals with sickle cell disease, other than due to their sickle cell disease. I have diabetes very extensively in my family. My mother had diabetes, my brother had diabetes, my grandmother had diabetes, and diabetes can be another cause of chronic kidney disease. So it's important that we just don't focus just on sickle cell disease. We're making sure that we look at that whole person. You want to refer to a nephrologist or a urologist, and then you want to just screen here, and then you can see, through the schematic. And so there are treatments that we are looking at for sickle cell nephropathy. So as it was mentioned, hydroxyurea. I'm a huge advocate. I'm the biggest advocate for hydroxyurea. But you can see here also ACE inhibitors, chronic exchange transfusions, in some cases hemodialysis, and then renal transplant. And so with that, I want to thank you, and please feel free if you have any questions to ask your questions.
Amazing. Thank you very much to our speakers for such an informative session. Wow. So now we're just going to open up the floor for maybe 2 to 3 questions, just to respect time. So we'll be happy to entertain those questions. Feel free to put your hands up, and we can run the mic over to you. Perfect.
Hi there. I'm a parent having a child with sickle cell disease. There's different types of sickle cell disease. There's SS, SC. Now, having sickle cell trait, and I'm trying to inform other parents about getting tested, they've always asked me, how does somebody get SS? How does somebody get SC? Is there different levels of sickle cell traits? I have a lot of sisters that that have the trait, and we all have different markers in our blood work, and we were just wondering, why is it so different from person to person if we just have the trait?
Thank you. Any one of our panelists, feel free.
So I'll say yes, there are different types of hemoglobinopathies, or different type of hemoglobin types. So SS would be what you hear most commonly. There is SC, so C, it does something different. And these are the genotypes of the hemoglobin molecule. So the hemoglobin will lead to the protein in the red blood cell. And so when someone says, oh, I have S, that means there's a certain change in the protein that causes S. C is a different change. E is another different change. And they all have a different impact. Now, trait means that you have one that's normal, that's one of your hemoglobin molecules is normal, and the other one is defective, either S or C. So you can have S, like hemoglobin AS, and so that means in one of your hemoglobin molecules, it's the S molecule, the sickle one that we think about. But you can also have AC, which is another defect, but it's not considered as severe. We're also starting to learn more about like the epigenetics. So, how much alpha thalassemia that could exist, or how much of these other modulators could exist as well, can have an impact on an individual. So if you have, let's say you have SS, but you have a certain level of alpha thalassemia, that could be kind of helpful to you in some cases. What I would say to you is that you probably want to have a genotype done. You want to go to someone that can really tell you, and they can do certain tests. So you don't want to do a simple blood test. You want to make sure you're really looking at the type of hemoglobin that you have. I hope that answered.
Were you trying to understand how somebody would get SS and somebody would get SC? Is that one? Okay, so, and can I ask, your son has SS? Okay, so that means you are a carrier for sickle. So you have one normal gene and one sickle gene, and his dad is similar, one normal gene and one sickle gene. And both of you passed on the sickle gene to your son. So he has sickle S from you and S from dad. And another person who has SC sees as a different hemoglobin, like Dr. Ivy said. So one parent would be a carrier for S, for sickle. One parent would be a carrier for C, and pass on C and S to the child. Okay, so both parents have to be a carrier for an abnormal hemoglobin, with one of them at least being sickle, to have a sickle cell, a form of sickle cell disease. So for example, one parent could have sickle and the other parent be a carrier for thalassemia. So that person would have sickle thalassemia, which can be as severe as SS. It depends on the type of thalassemia. Did that answer?
Yeah, when we've gone for blood work, some of us have like sickle cell trait and sickle cell thalassemia trait. So it was kind of hard to figure out why and like who to talk to, because most doctors hematologists don't really deal with somebody that has sickle cell trait. They just deal with sickle cell patients. So when we talk to our doctors about it, they really don't know how to educate parents about that. So it's hard to kind of give that information on to other parents, trying to educate them, because we've had to, like, we're trying to tell other parents, like, to get tested. We also have, like, a lot of nieces and nephews that are one day going to have a child, and we don't know how to explain to them what makes that gene, and we all have different markers in our blood test. I don't know if that...
I don't know if you will be here tomorrow, but there's a special session on that tomorrow, talking about sickle cell tests for carrier. So I will invite you to participate to that, but I'll let them respond.
Perfect. Thank you. You want to respond?
Oopsie. Hi.
Oh, sorry.
Hi, thank you for your presentation, all three of you. I had a question about kidney, sorry, hold on. Renal medullary carcinoma in sickle cell trait patients. I'm just learning about this now. My daughter has the trait, and now I'm wondering, what should we be checking something? Because she's in her 20s. I understand it affects individuals when they're younger, a younger age or whatever. So I'm wondering if that is something that we should be checking as well.
Hi, so thanks for that question. You're right. I didn't speak about renal specific findings in patients with sickle cell trait, but that there is an increased risk of certain kidney diseases with trait, one of them being renal medullary carcinoma, so that's a specific type of cancer that can affect the kidney. There are not a lot of screening guidelines, to be very honest with you. The important thing is that people are aware when they have trait status that this is one of the complications that people can have, and one of the ways that that can present is through blood in the urine. And so it's really sort of counseling on what that looks like, and making sure that there is prompt referral. Typically, usually there would be a referral to urology and a kidney specialist concurrently to evaluate that, and the person making the referral needs to sort of indicate this is a person with sickle cell trait, and we do recognize these renal specific complications with this trait status. There can be pain as well, because sometimes what's happening is that blood is forming within the kidney tissue, and that can sort of stop, it can block the outflow of urine, and so people can have painless blood in their urine as part of that manifestation. Yeah, you're welcome.
Okay. I have a question. It's based on that as well. Do people with thalassemia trait have the risk as well?
Hi, I'm so sorry. I didn't see where that question came from. Oh, in the back. Okay. Yeah, as far as myself and the other panelists are aware, there is not a clear linkage between thalassemia traits and that particular kidney complication of renal medullary carcinoma.
Thank you very much for your presentation. I was wondering whether you can share any tips on increasing exercise tolerance for patients with sickle cell. I'm a parent of a child who has sickle cell SC, and transitioning into adulthood where she wants to be fit like her friends, but unfortunately her stamina in the gym is not the same as her peers, and it leads to discouragement. And so I was just wondering, can you speak to what I can do as a parent to help with the exercise tolerance? Thank you.
Yeah, I would say, and this is just from my personal experience, I let them handle the medical part. I was fortunate in that at the same time I started taking hydroxyurea, I moved in, two new roommates that were football players. And that kind of got me into it. One thing is she has to know kind of where her limits are. That would be an important part of it. Is understanding, okay, well, what would bring on a crisis? Like, when do I need to stop? Making sure she's hydrated and making sure she's taking those other precautions. I'm going to say this as a sickle cell patient, not as a doctor, that then I would encourage her to kind of nudge the limits a little bit, because that's how you build that stamina. That's how you build that tolerance. That's how you build that. So she definitely needs to know where those limits are, and then kind of push against them so that she can get more of that stamina, build more of that muscle, do more of that thing. And I think over time she'll figure, hey, I can push a little more, I can push a little more. So maybe she has to start with, I'm only going to walk for 15 minutes a day for a week or a month or so. Hey, I'm going to then move up to 20 minutes a day, 25 minutes a day, and gradually increasing. But she wants to also just know those things that can cause a crisis to avoid those.
Amazing. Awesome. Thank you for that. And thank you to our speakers for sharing their expertise and perspectives with us today. And thank you to everyone in the audience for your participation. Please join me in thanking our speakers before they leave the podium.